Welcome to the A&D webinar, National Patient Teacher Registry, a new educational concept. Your speaker for today's program is Mark Korson, MD, Director of Physician Support Service and Director of Education at VMP Genetics. Audiocast quality is subject to your equipment, available bandwidth, and internet traffic. If you experience unsatisfactory audio quality, please use the telephone dial-in option provided in your confirmation and reminder emails. If you have dialed in, operator assistance is available by pressing #. A question and answer session will follow the presentation. You can then send your questions by using the Q&A box located on the lower left of the presentation screen. Type your message at the bottom of the Q&A box and press enter to send it. Remember, the question and answer session will follow the presentation. I will now turn the call over to Dr. Korson. Dr. Korson, please begin.
Thank you so much. I am Mark Korson, and just to give you a little bit of background, I'm a pediatrician. And I then focused after my pediatric residency on studying genetics, clinical genetics and biochemical genetics, also known as metabolic genetics. And that's how I became acquainted with patients and families with metabolic disorders, including Pompe. So I did my training at Children's Hospital in Boston, and I've spent the next 25 years after that following patients and families. And it is because of my experience in these areas that I've come to identify a need for education in order to increase access by the patient community to metabolic expertise. So let me begin. So first of all, I want to thank the organizers for this invitation to present this project, which is a collaborative effort based at VMP Genetics in conjunction with the students in the Master's Genetic Counseling program at Boston University. The concept is the National Patient Teacher Registry, but the idea behind it is that while I teach, patients teach a whole lot better than I do. Now remember, teaching is a part of any genetic or academic training program or clinical practice, and it occurs in many different formats. Typically, teaching is a didactic process where there's somebody at the front who teaches the audience. More and more, it's interactive. But generally, it occurs by a professional who has studied the topic or who has experience in the clinical realm. And what I am presenting today, though, is putting the patient, putting the family member in the teaching role. So the objectives today, I want to discuss the challenges resulting from inadequate awareness about metabolic or biochemical genetic diseases. I want to identify the educational benefits in empowering patients to tell their stories. And I'll be describing the development of our program that promotes live and online patient teaching. So what's the problem here that spawned this project? Well, there are not enough biochemical or metabolic geneticists to meet the clinical demand. And this is particularly acute in the area of biochemical genetics. This is a photo of the number of certified medical specialists in the various genetic subspecialties. It's taken from the American Board of Medical Genetics website. So let's take a closer look at these data. The number of certified professionals specializing in clinical and medical genetics, so that's that's physicians who specialize in taking care of patients with metabolic disorders it numbers about 426. However, this number includes those who work full-time in a laboratory setting, those who came to train in the United States, took their exams here, may have gone back to their home countries, and those who have retired or even passed on. But whatever, they're all unavailable to the patient community in the clinic. In fact, it's estimated that there are only about 130 to 140 clinicians who actually care for patients, for metabolic patients in the US. Some data suggests that up to half the clinics in North America, mostly small ones, are directed by doctors who have no formal training in metabolic disease. They're really doing it out of circumstance, since there's no one else around in their institution to serve in that role. So the American College of Medical Genetics last fall conducted a workforce survey. And it turns out the number of genetic counselors who responded to the survey was about 4,700, meaning, and when you take that against the population of the country, there are about 7 counselors per 500,000 people. The number of actual geneticists, though, number only about 1,240, or 2 per 500,000 people. And of course, that's not evenly spread throughout the country. From the time of the last survey, which was about 10 years before, the number of genetic counselors fully doubled in number, but the number of geneticists has not kept pace in the same way at all. But the truth is, despite the survey, the actual number of practicing geneticists is not quite known. So unfortunately, when a geneticist dies, he or she does not report himself or herself to the board saying, I'm dead. So there are numbers in there that should be deleted. There are people who have retired that are still officially listed as practicing. And the other thing we don't know is the ideal size of what should the ideal size of the genetics workforce be. No one has that data. We're not experienced enough in this area of medicine to know that. So more important is how many vacancies are there for clinical genetics jobs. So on the bottom axis are the number of vacancies for a particular institution, and on the left axis, are the number of individual programs. So what it shows is there are about 130 programs that have 1 clinical genetics job vacancy. There are about 80 programs who have 2 job vacancies, and then a much smaller number of hospitals are looking for 3 or 4. But this is really telling. This is the length of time that a job vacancy has remained open. So you can see that 35 hospitals have had a job vacancy open for for 7 to 12 months. And if you add, and then if you look at 13 to 24 months, there are 40 programs who have been waiting almost 2 years to fill a position. And then beyond that, there are about 20 programs that have been waiting 3 years, and another 20 programs who have been waiting longer. So clearly, there is a shortage of people working in this area. So why is there a shortage? And why is it a particularly severe clinical challenge? Well, most metabolic diagnoses have traditionally been made by clinicians trained in this area of medicine. While the clinical demand for metabolic doctors is rising, the number of trained clinicians is not. And there's no foreseeable rise in the number of trainees who are going to evolve and become metabolic physicians. Unfortunately, it's not as if other specialists who see these patients in their clinical practices can just pick up the slack, since teaching about metabolic disease is really inadequate in the vast majority of medical school and postgraduate training programs. Let me read this article from the Boston Globe, published October 17, 2017. During match season for medical trainees this year, so that's back in 2017, just 30 of the 55 spots for the medical genetics residencies in the U.S. were filled. And I might add, some of those were filled by foreign applicants who are more likely to return to their home country. So I think you can appreciate the problem here. Genetic disorders are multisystemic, and undiagnosed patients populate a range of specialty clinics, typically before they end up in genetics, if they ever get there. But if specialists don't recognize a patient, then a diagnosis can't be made. And without a diagnosis, patients and families are missing important information about their medical condition, about long-term expectations, their options for therapy and disease-specific support, how to prevent complications if possible, what is the risk of other family members having the same condition, and what is the risk to their future offspring. Fortunately, there is newborn screening for Pompe disease, and as you can see from this updated map, these are the states that have included it, have mandated screening for Pompe disease. So this is very useful in identifying new cases, but there are lots of patients in the pediatric community, and even more so in the adult community, who are wandering around with symptoms with no known cause, but they actually have Pompe disease. So so newborn screening is a good plan for moving forward, but how do we address the problem that's with us now? So let's talk a little bit about teaching. Sir William Osler was a very important physician who also promoted and advocated for medical teaching. And I quote, "To study the phenomena of disease without books is to sail an uncharted sea, whilst to study books without patients is not to go to sea at all. And medicine is learned by the bedside and not in the classroom." Now, teaching has changed over the years. In the 1960s, 75% of clinical teaching occurred at the bedside. That's where medical students and postgraduate doctors learned medicine. But by the time 2013, when this article was published, it was only about 8 to 19% of clinical teaching was occurring at the bedside because of new imaging, lab testing, technology. And so all the teaching got switched into the classroom or the conference room on a hospital ward. But bedside teaching remains the gold standard for learning how to talk to patients. You can do all the role playing you want in a classroom, but you really have to talk to patients a lot to figure out how to best communicate with them. And it's the gold standard for learning about medical ethics, about making good judgment, good decisions, using good judgment. That requires active patient interaction. In one study in 1980, it was shown that a thorough history, if you really spoke to the patient or family member, took a really comprehensive history and did a physical, you could arrive at a correct diagnosis in 73% of cases, and for certain problems, over 90%. Now, granted, this was relating to cardiac disease, but the same is true. Often, because of demands on the ward, the time that we have to spend with patients is reduced. And so it's unfortunate because the best screening test that we have for diagnosing patients is not blood tests, it's not urine tests, it's not MRIs, it is taking a thorough history. Oops. So why am I promoting excuse me, storytelling? Because storytelling, while I teach facts, patients tell stories. And storytelling, long after I have finished my teaching, if I introduce a patient, years later, many of those students will not remember that I taught them anything at all, but they'll remember the person who told a story. And why is storytelling so powerful? 3 concepts. Neural coupling. Neural coupling is when the story is so engaging that the listener merges the story with his or her own experience and makes it more meaningful. And I would urge you, think about great movies that you have seen that have really reached into your heart, or a great play, or a great book that you have read. Because we put ourselves into those stories, and that's why it hits us hard. The concept of mirroring, where an effective story enables the listener to live those events himself or herself. And important, the release of neurotransmitters, where if stories tug at our heartstrings, they cause a release of dopamine. And if we have an emotional response to a story, we are going to remember that story more accurately. So if you can couple a good story with facts about a disorder, hopefully that story will pull those facts in with and get lodged in the brain. And so that's the effect of a memorable experience. So the powerful human dimension of a story resonates and stays with us. Think of it. Are you more likely to remember a lecture or a movie or a book? And so we are trying to replicate that here. We also believe that those who have heard a story about a disease are more likely to recognize that disease again. Now, patients can be experts in their own disease, and in general, they love to teach. They want to increase awareness, and they're tired of meeting professionals who know nothing about their condition. And if they teach, they know themselves and their own diseases better, and informing others can enhance the quality of the care they receive or their child receives. So, how are we going to promote the patient teaching concept? We are working on developing a registry of patient teachers throughout the US and perhaps Canada as well. It will be available on an educational webpage at my company, VMP Genetics, and we're going to promote it to those professionals who teach about these disorders. So, medical clinics, genetic counseling programs, and other healthcare training settings. And don't forget first-year biochemistry. Remember, metabolic disease or metabolic genetics or biochemical genetics is the direct clinical application of biochemistry. Show me a chemical pathway, and I'll find you someone who can talk about living with a defect in that pathway. What it does is it puts the human in human biochemistry. So what is posted for viewing on the registry will not include specific or identifying information about the patient, but rather just the diagnosis and the location. Requests are expected from local or regional teaching institutions and venues around those geographical areas. So we are approaching more than 85 patient foundations that are oriented around metabolic disease to ask permission to post a recruitment notice on their websites or in their bulletins or somehow on their social media. Interested patients and family members are informed about the project. We discuss what teaching might look like in the classroom, and we answer their questions. Usually, the audience is going to be prepped with a medical overview of the condition, so they'll have some sort of background in what they'll hear from the patient so they better understand what the patient tells them. And then the patient, and of course, when I say patient, I also mean it could be the caregiver or both. And when a patient or caregiver talks about the range of topics, it could be living with a disorder, their diagnostic journey, the challenges of the healthcare system or insurance, their challenges at school or in the workplace, what doctors do right and what they do wrong, and so on. And we ask that patients participate in an informed consent process to sign on to the effort. So they have a full understanding of what we're going to do, and we have know that they've heard the details of the program. So how is the process, how will it work? Well, an educator will scan the registry to find out what patient diagnoses are in their area. She or he submits a request to VMP Genetics, and a project representative from VMP will confirm the credentials of the educator making the request, making sure that she or he is who she says. And if confirmed, the patient teacher is then notified to follow. So really, it is up to the patient or caregiver to touch base then if they would like to participate with the educator. And then after the event, a project representative will get feedback from both the educator and the patient teacher in order to improve the program process. And we can also serve to help new patient speakers so that they learn and improve their skills in speaking to medical audiences. To date, we have approached 86 disease foundations, and 20 foundations so far have agreed to participate and have posted announcements about the registry on their websites or social media outlets. Also, I know of additional several dozen patient teachers, and I'm reaching out to them, not through foundations, but to enroll them as well. But in total so far, we have about 76 patients or family members who have responded, who want to be involved, and who have signed consent. In addition, we are looking to provide guidance for those, again, new speakers who would like to tell this story, but are a little shaky about standing up in front of an audience. So we can discuss the principles of good storytelling, what things they can do to prepare, maybe even do some role playing, and then again, debrief them after the presentation to get their feedback on how it went and how they might improve their performance in future. So far we've been talking about live teaching opportunities in which patients or family members physically come to a teaching venue, usually at a medical school or a university or a health center. And these kind of teaching sessions typically go about 45 to 60 minutes in length. However, sometimes an educator is not able to devote a full hour to a patient speaker. They might only have 5 or 10 minutes for this kind of thing. So in the research process, as we've been reaching out to foundations, we've identified dozens of videos showing patients or parents or caregivers talking about their diseases. Most are about 5 to 10 minutes in length. And these are useful for educators who don't have a whole period to devote, but want to enhance the quality of their lecture, and so would download such a video and include it in their presentation. The sources of these videos are generally from disease foundation websites or pharmaceutical company YouTube channels. And I'm talking about really educational videos, not promotional ones that advertise the use of a drug or a device. And these videos are already posted in the public domain. The problem is people or educators don't know that they're there. I mean, they're out there, But if you're looking, unless you look hard, sometimes you can't find them. So the registry will also include a catalog of existing videos that'll include the disease name, of course, and a summary of the content, some technical details, and a description of the educational value of the video, since the teaching quality can be very variable. Some are really self-standing and good teaching tools, and some require some factual medical accompaniment. So, what I'm going to do now is introduce you to Zoe. This is a 10-minute video. We're going to only watch the first 7 minutes or so. And this video was put out, developed by the National Urea Cycle Disorders Foundation. Now, it has nothing. The urea cycle disorders have nothing to do with Pompe disease. But the point here is to show the power of teaching, especially a video. So let's watch together.
What's your hobbies? My hobbies watching dance, singing, dancing, and my favorite present is, let's see, the boombox, and it holds 5 CDs. 5. Zoe? Yeah? What do you want to be when you grow up? A singer and a dancer. Or else a chef. A chef. Okay.
It's so really hard for me to describe Zoe in just a few words. To me, she was just extraordinary, and I mean, I know I'm a little bit biased, obviously, but I think that anybody that met Zoe, I kind of thought the same thing. She was just unforgettable. Zoe was a 19-year-old, almost 20-year-old. She was a student at the University of Arizona in Tucson. She wanted to be a nurse. She died suddenly last December of an undiagnosed rare genetic disorder called OTC deficiency.
In individuals who have mild forms of urea cycle disorders like Zoe, the patient may go unrecognized for years before a diagnosis is made, and it's really not until a perfect storm of triggers comes together to produce a catastrophic elevation in blood ammonia levels. Certainly, the blood ammonia level, when it's elevated, if it's not recognized, patients may progress very quickly to coma and death.
Patients can present with being lethargic or with GI symptoms like vomiting. They can also present with seizures or personality changes, and ultimately may lead to even coma.
In her teens, she started to have these episodes of nausea and vomiting. They were completely random. She would just feel sick and be sick, and then it would pass, and we could never really quite figure out the cause of it. We talked to the doctor, and but they weren't, we thought maybe she had food allergies, but nothing ever really seemed to, nobody said it seemed like it was serious, and it was so, like I said, it was so sporadic, we couldn't really pinpoint anything. Looking back now, it's easy to see that she avoided protein. Right after she went back to Tucson for her sophomore year, it was in September 2015, we got a call one night that a few of her friends had taken her to the emergency room. She had been really tired, and the nausea and vomiting were continuing, and the most worrying symptom was, though, that she was very, very confused. She couldn't, she kept repeating herself, and she was disoriented, and she her text messages. She would repeat them and they would be garbled. At the hospital, they ran a variety of tests. They gave her blood tests and CAT scans and MRIs, and of course they screened her for alcohol and drugs, and it came back completely negative. They kept her for a few hours, and they decided she was dehydrated, and they gave her IV fluids, and they released her they gave her an anti-nausea medication, and they sent her home. Zoe never really felt completely well again. The next couple of months, she continued to struggle with the nausea and vomiting, always really tired and lack of energy. My bubbly, enthusiastic girl was short-tempered and irritable a lot of the time, and she just wasn't herself.
There are certain triggers that increase the risk for high blood ammonia levels in patients with urea cycle disorders. These triggers may include things like a viral illness, an infection, going too long between meals, surgery, or pregnancy or delivery, or even things like dehydration or excessive exercise. In addition, other well-known triggers include a protein-rich diet or even a protein-rich meal and gastric bypass surgery.
A lot of times ammonia levels aren't drawn routinely in the ER setting because oftentimes doctors don't think about the diagnosis of a urea cycle disorder. These are, in theory, rare conditions, but because they're so easily detected and there are so many good treatments, it's critical to be thinking about these conditions because the consequences can literally be life-threatening.
2 days before she was scheduled to fly home for Christmas break, she was found unconscious in her apartment. They rushed her back to the same hospital, and they immediately suspected alcohol poisoning. But they did they checked her alcohol and drug level, and there was absolutely nothing in her system. They gave her every kind of test you can imagine. She had so many doctors, neurologists and pulmonologists and infectious disease specialists and seizure experts, and nobody could figure out what was wrong with her. During the whole time, she was never given a blood ammonia test, and it's a simple test that would have measured the amount of ammonia that was in her blood, and it would have probably pointed us in the direction of finding out what was wrong with her at that time. But she never had that test. On December 24th, we said goodbye to Zoe, and Christmas was always Zoe's favorite holiday. So.
All right. So, all right. So we've just watched that video, and let me recall to you the three concepts I mentioned earlier. The concept of neurocoupling, where the listener or the viewer merges the story with his or her own experience to make it more meaningful, or actually lives those events if the stories are similar enough to their own. And the concept of release of neurotransmitters, where emotional stories cause a release of dopamine, and that promotes better recall in the viewer or listener. So let me tell you, I've used this video a number of times for medical audiences where those physicians see acutely presenting patients. At the American College of Emergency Physicians annual meeting, I presented a lecture on metabolic patients who present acutely with mental status changes or coma. And before my presentation, I asked the audience, how many of you draw an ammonia level in patients who present with lethargy or coma? And zero, nobody said yes. We did the presentation, they saw the video, over 95%, when asked the same question at the end, said that they would now do an ammonia level. Now, I like to think that my teaching is really, really that great, but really it's Zoe that made the case for me. So, there are aspects of storytelling that can be done in both the live setting, but also in a video. And the importance is to, again, not just convey facts, but tell stories or mix the two together. And that's what we are hoping for. So, getting back to our registry and its companion video catalog, this is not just something that we are offering doctors. We are hoping to make this available to biochemistry educators. And I will tell you that the Association of Biochemistry Educators, they are the course directors of biochemistry courses at over 140 medical schools on the continent. They're all set to use this. So they just want access to patients and patient videos. We're going to make this available to neurologists and gastroenterologists and other subspecialists. We're going to make this available to other clinicians and educators in medical schools and in other programs like genetic counseling, like nursing, and so on. To be open, because as this project expands, we want to remain responsive and be able to keep up with the latest technology. We are going to be seeking sponsorship to support the operating costs and the promotion and expansion of this program. So, getting back to my opening statements, yes, I can teach, but you as patients and caregivers, you can teach a whole lot better than I can. And so I'm glad, I'm delighted that the AMDA is partnering with us to find us patient speakers who want to help in the teaching effort. So thank you, and I'm happy to take questions.
You can send questions using the question and answer box located on the lower left of the presentation. Type your message at the bottom and click Ask with your mouth to send it. Dr. Korson.
Yes.
How can a patient get on that registry to tell their story?
Okay, so we have a dedicated email that would be the best way of reaching us. If you notice my email address at the bottom, mkorson at VMP Genetics on the screen, genetics.com on the screen in front of you, you can either write to me directly or write patient teacher registry, all one word, at vmpgenetics.com. So either write to me directly or patient teacher registry, all one word, at vmpgenetics.com.
Thank you, Doctor. I have another one for you.
Sure.
If I volunteer, how can I make sure that my name isn't out there on the internet? Can you review how confidentiality is maintained?
Sure, absolutely. While we are talking and getting and reviewing the process with the patient speaker, we collect information and content information that remains only with us, and it is stored in a confidential, secure storage area at VMP Genetics. When we, what you will see in the on the website, though, is you will see only either a map of the United States or a list of states and or city regions, and the name of the disease will be listed there as well. So just the geographical location and the disease for which a patient speaker is available. The viewer of the website will not have any additional information other than that. If the educator, say there's an educator in Chicago, looks at the website, and under the website it says there's a patient with a urea cycle disorder and Pompe disease available in the Chicago area, the educator would reach out to VMP Genetics. We would confirm his or her credentials to make sure that he or she is who she says or he says he is. And then once we can confirm that, we will, not the educator, we will reach out to the patient speaker and let them know that there is a request. So, and then it's up to you to reach out to the educator. So we will also confirm with the educator that they are not allowed to disclose without your permission your name, like your name within the class. In other words, so it's not printed. So from our standpoint, there's no way to get your name. It's only if you divulge it to the educator.
That's wonderful. I have another question for you, Doc.
Yes.
If I have no particular experience in speaking to medical people, it actually sounds a little daunting. Is there any way I can get some training around how to do this and do it well?
Absolutely. It's not easy to stand up in front of 50 or 100 people. So actually a little easier doing it on a Zoom call, and we're having some patients who are actually presenting in a Zoom call, so you're not actually seeing the whole audience. But yes, I have seen many patients present, for their first time, and they actually do wonderfully. But it does take some preparation, like, for example, going back over your journey, your experience as a patient or as a parent of a patient. And what you don't want to do is simply list a chronology. In 1981, this happened. 1993, this happened. 94, this happened. What you want to do is take the milestones of your experience and tell stories associated with that time. Like, what was it like when you heard the diagnosis? What was going through your mind? Describe that hour. Describe that day. When you went to the hospital because you collapsed, what was that experience like? Take those milestones, because those are what's going to tug at heartstrings and get patients to remember what you're saying. But we have counseled many patients and gone over together what they might talk about, and you will do fine. And afterwards, we'll go over it, because this is a process. This is an art that everyone who tells stories has to develop. So you improve with time.
Okay. All right. Now, let's say that I have registered and I get an email that a professor in my city or town or county wants someone to speak about my experiences with Pompe disease. What happens next?
We will give you the information. So if we've notified you, we've already vetted that request, and that whoever requested is in fact a faculty member at a local medical school or health organization or hospital. And we will have let them know how the registry works, and that we will be sending you, the patient speaker, their name and their phone number to contact. And we'll speak with you and give you their information. If you say, oh yeah, you know what, I'm not interested in doing this anymore, or I have too much going on, or my medical issues are too complicated right now, I can't afford the time, then we'll touch base with the educator. But if you say that you would like to participate, then at that point we give you the information to move forward. But we also tell the educator that they have the responsibility of protecting your privacy if you don't want your name included in their curriculum agenda or something like that. But that's, so at that point, we leave it to you to make contact.
Got it. Doctor, I've got a question that's come in that I was going to ask. It says, do I get paid for speaking to a medical school class or a hospital group?
So there is no, in the vast majority of cases, there is no payment for actually speaking. What some medical schools do, and some teaching programs, is they do have an honorarium for speakers. That happens, and if you incur any costs in the process of teaching, like you're traveling to get downtown into the city, or parking while you're downtown, they'll often cover those costs. And that is generally reviewed by the educator when they engage you. But VMP Genetics does not provide any money, and not all education programs do. Some do, and some have allowances for that, and some don't.
I understand. And to me, if where you have to go is close, then making this a lot easier for the people that come behind you should be payment enough. But that's just me. Doctor, I have another question for you, and it's a really good one. Is there any vetting process for the patients to ensure that they have the basic knowledge enough so that their disease can be presented in a responsible way? If they're a teacher, for example, the information they may spread has some degree of accuracy. Is there a vetting process to be sure that the people that have volunteered know enough about their disease to properly present it?
Well, that's a really, really good question. So first of all, we only work with patients or caregivers where there's a definitive diagnosis. And so I speak with every patient in advance of the speaking engagement to make sure that we're all on the same page, not only about the teaching process, but about the disorder and what they know about the disease. Now, remember, they're not teaching about the disease. I actually, the way these work for me is when I engage a patient, I give a 10, 12-minute overview of the disease in advance so that the audience has a good foundation of the disease and what they're about to hear, so they'll better understand what the patient is saying. It will make more sense to them. If I will have vetted that patient and what they were saying, and during the talk, if I hear something that is odd, then what I do is I comment about that after the patient is speaking. That won't necessarily be the case That won't necessarily be the case in situations. So that is a potentially a bit of an issue, but we are not asking patient teachers to teach about the disease. We're asking them to teach about their experiences. But I will also say that we are looking for patients who have I don't want to call useful or relevant are bad adjectives, but who have more typical presentations of the disease. We don't want somebody who has perhaps a disorder who has such wildly unusual symptoms that they can actually be misleading to the audience. So, for example, if a patient with Pompe disease gets hit by 3 trucks and so talks about having Pompe, and if you have Pompe, you get hit by 3 trucks, that's completely misleading. So that would not be, we would vet them out. And so as part of bringing patients in, we can't vet everything, but we do try to make sure that they have at least a typical presentation for their disease, and that their disease is has a certain diagnosis. Does that answer the question?
I believe so. Doctor, I have one last question for you.
Sure.
What made you decide to start a patient-teacher registry? How did that concept come into you?
Well, in the 25 plus years that I have been seeing patients, it became clear to me that there were not enough of me. And I don't mean enough of Mark Korsons, I mean enough biochemical geneticists. And that patients were going years and years and years without a diagnosis. In fact, it is believed that within the metabolic doctor community, that the majority of patients who have metabolic diseases live on this planet, live and die without a diagnosis ever being made. And so there's a terrible shortage of us. And so we are grappling with not meeting the clinical need. But we doctors aren't just supposed to be treating patients and families, we're supposed to be teaching. And we can't do that by ourselves. So as I was developing the concept of how to teach more about metabolic disease and how to reach specialists and their trainees, I suddenly realized that I don't have to do this alone. I can have people collaborate with me. Very powerful teachers collaborate with me. I had seen patients explain their stories. Sometimes they would bring me to tears. And why can't we harness that power and utilize that? And therefore, if I could set up a registry, then this project, this proposal that I have, can go way beyond me and can enhance metabolic teaching to a far greater degree than what I alone can do. And then talking to other educators, like the biochemistry directors of the medical schools, as I told you. In medical schools, some departments think biochemistry is not relevant because there's so many more, or shouldn't be a priority because there's so many more important things that medical students should learn. And so biochemists are looking at me and they're saying, can you help us prove that we are relevant? Well, I sure can, because you show me a biochemical defect, a biochemical pathway, and I'll introduce you to a patient who has a disorder in that pathway. And so I am helping them prove their relevance, and they are enhancing their teaching by including patients in the teaching process, which medical students love. So So it's recognizing that there is such a shortage in this area, and with implications for patients who are going years without a diagnosis, if they ever get a diagnosis, and we can do a whole lot better. And so I'm looking for help, and that's why I'm speaking to you.
Thank you, Doc. I misled you in saying that was the last question. I have one more, and
Okay.
we're pushing time on it. If we are interested in the program, is there a way we can help advertise it, at our local hospitals or medical schools?
Absolutely. So we are hopefully going live in January. And so at that point, we'll have more specifics. We will generate flyers that we can circulate to you. And by all means, take it to the medical schools. We will be going through the Association of Biochemistry Educators to get into the biochemistry courses and asking them to circulate it to their medical schools, to other specialties, and to circulate it to their affiliated hospitals. But if you can do it on our behalf, absolutely. The more, the better.
Yay. Dr. I'm going to ask you for a closing statement or comment. And if you, during this, can answer one more question.
Sure.
How many other diseases are represented in your registry besides Pompe?
Right now, about, I think, 22. So we have several speakers. We have several speakers for a number of different disorders.
All right.
So we're on our way.
Any
I mean,
closing?
it's interesting. I'm sorry. Go ahead.
No, please finish.
Oh no, it's we reached out to 85 different foundations, disease foundations, and we're discovering that different foundations are structured differently, and the responsiveness is different, and the priorities are different. Everybody, all the foundations prioritize raising awareness, but it's taking some time for us to really engage them so they can they can collaborate with us in a productive way. So we're patient, and we realize that this program is going to expand over time, and we just have to give it time. So I'm happy with the progress so far.
Yeah. Okay. Thank you, Doctor. Everybody should know also that if you would like to have handouts of today's webinar, if you go back to your registration page and just below the spot where you signed on, you'll see program materials. If you will click that link, that will take you directly to where you need to go. This has been a wonderful experience, and we hope that you all have enjoyed it. We hope that it touches you and motivates you. This will conclude today's AMDA webinar.